Most people over 60 who have a stroke did everything they were supposed to do. They took their blood pressure medication. They watched what they ate. Some of them walked every morning, and they still ended up in the ER, unable to speak or unable to move the left side of their body. What nobody told them is that their blood was already working against them, not because of stress, not because of diet, but because of something written into their DNA at birth. I'm Dr. Anika Mehta. I'm a cardiologist, and the difference, in many of those cases, came down to blood type, specifically the difference between type O and everyone else. There is one protein your body produces in wildly different amounts depending on the blood type you were born with. That protein is the reason some people's blood clots faster, more aggressively, and in the wrong places. And after 60, it becomes the factor most doctors never check. Let's start with the basics, because understanding the mechanism is what makes the rest of this actionable. Your blood type is determined by proteins called antigens that sit on the surface of your red blood cells. If you're type A, you have A antigens. Type B, you have B antigens. Type AB, you have both. Type O, you have neither. You learned that in school, probably, and then forgot it because it seemed like trivia. Here's what they didn't teach you. The same gene that decides which antigens sit on your red blood cells also controls how your blood clots. Not indirectly, directly. The ABO gene regulates the production of a protein called von Willebrand factor, VWF for short. And VWF is the central character in everything we're going to talk about today. Think of VWF as your blood's emergency responder. The moment a blood vessel wall gets damaged, VWF floods the area, grabs circulating platelets out of the bloodstream, and starts building a clot to seal the injury. It's a critical system. Without it, minor cuts wouldn't stop bleeding. The problem isn't that VWF exists. The problem is how much of it you're carrying around at any given moment. And that amount is largely set by your blood type. People with non-O blood types, A, B, and AB, produce roughly 25 to 30% more VWF than people with type O. Type O individuals clear it from the bloodstream more efficiently. Non-O types don't, so the levels run consistently higher from birth. Picture two patients sitting in my clinic. Same age, same blood pressure, same cholesterol, same lifestyle, same weight, same medications. One is type O, one is type AB. Before I've ordered a single test, the AB patient's blood is already in a measurably more pro-clotting state. The baseline is different before we've even started. In your 30s and 40s, that difference sits quietly in the background. Your arteries are flexible. Your vessels handle the extra clotting activity without incident. The risk is there, but the body compensates. After 60, the compensation starts to break down. Here's what most cardiovascular risk conversations miss entirely. VWF levels don't stay fixed across your lifetime. They rise with age. Starting around 40, your circulating VWF climbs roughly 1.5 to 3% per decade. Not because of anything you did wrong, but because your blood vessels are aging. The endothelial cells lining those vessels become less efficient, more inflamed, and they release more VWF as a result. By your late 60s and into your 70s, your baseline VWF is measurably higher than it was 20 years ago, regardless of your blood type. For type O individuals, that age-related climb still keeps them within a relatively safe range. For type A, B, and AB individuals, it doesn't. Because the age-related rise doesn't add to zero, it stacks on top of an already elevated baseline. What was a modest clotting advantage in your 40s becomes a compounding cardiovascular liability in your 60s and 70s. The gap between blood types doesn't stay constant with age, it widens. Most of my patients are surprised when I tell them the clotting risk isn't actually the most dangerous part of this picture. What makes it dangerous is what's already changed inside the arteries by the time the clotting system starts pushing harder. And that combination has a very specific effect I want to walk you through. And something else changes after 60 that makes the timing even more dangerous. Strokes in younger adults are driven primarily by clotting events. A clot forms in a relatively healthy vessel and causes a blockage. Post-60, that picture shifts. By the time most people reach their late 60s, there is already some degree of atherosclerosis, plaque building up along arterial walls, narrowing the channels that blood flows through. Those narrowed, plaque-lined arteries are less forgiving. A clot that would have been a minor incident in a wide, flexible vessel becomes a catastrophic blockage in one that's already compromised. So you have two processes accelerating at the same time: clotting factors rising with age, arterial tolerance dropping with age. In non-O blood types, both of those curves are steeper. The REGARD study, a large bi-ethnic cohort that followed more than 30,000 adults over 5.8 years, put a number on this. Compared to type O, people with AB blood type had an adjusted hazard ratio of 1.83 for incident stroke. That means nearly double the risk. And that figure was calculated after accounting for hypertension, diabetes, and every other conventional stroke risk factor the researchers could measure. The blood type effect was independent. It wasn't explained away by lifestyle or comorbidities, and when the researchers dug into what was driving that association, factor VIII explained roughly 60% of it. Not as a contributing factor, as the primary engine. What makes this genuinely dangerous is that none of it produces a warning signal you can feel. Most patients with chronically elevated VWF and factor VIII have no symptoms. No pain, no fatigue, no warning. Blood pressure controlled. Cholesterol acceptable. The standard panel comes back unremarkable. The first sign, in too many cases, is the stroke itself. So if you're type A, B, or AB and you're over 60, the question isn't whether this applies to you. It does. The question is, what's actually happening in your blood right now, and what you can do about it. To understand why blood type matters so much after 60, you need a clear picture of what's actually happening at the vessel wall level. Not in abstract terms, in real, physical terms. Imagine your bloodstream as a river running through thousands of miles of pipes. Most of the time, the water flows smoothly, no turbulence, no obstruction. Now imagine that along the inner surface of those pipes, there's a thin protective lining, your endothelium. That lining is both a physical barrier and an active signaling system. When it's healthy, it keeps blood moving freely. When it gets scratched, inflamed, or cracked, even slightly, it sends out an immediate chemical alarm. VWF is the first responder to that alarm. Within seconds of endothelial damage, VWF molecules are released from storage, and they unfold into long, sticky chains that anchor to the damaged surface. Those chains then reach out and grab platelets flowing past in the bloodstream, pulling them out of circulation and packing them into the wound site. That initial platelet plug is the foundation of every blood clot your body forms. In a type O individual, that process works. But the VWF chains are shorter, clear faster, and the platelet recruitment is proportionally more contained. In a non-O individual, especially type AB, the VWF chains are longer, stickier, and stay anchored longer before the body dismantles them. The platelet recruitment is faster and more aggressive. That initial plug grows larger, and once the plug is established, factor VIII, the second clotting protein that rides along with VWF in greater quantities in non-O types, amplifies the downstream cascade, accelerating the conversion of fibrinogen into fibrin, the structural protein that locks a clot into place permanently. In a young, elastic artery with a wide lumen and healthy walls, this sequence plays out and resolves. The clot forms, seals the minor damage, and the body's natural breakdown enzymes dissolve it cleanly. The system works the way it's designed to. In an older artery, one with years of plaque accumulation narrowing the channel, stiff walls that flex less, and an endothelial lining already under chronic stress from decades of blood pressure fluctuation, that same sequence doesn't resolve so cleanly. A clot that forms in a vessel already running at 60% capacity doesn't need to be large to cause a blockage. It just needs to be in the wrong place at the wrong moment. That's why the regards data showed AB outpacing even type A in stroke risk. AB individuals aren't just producing more VWF. Their bodies also struggle to break it down fast enough. The VWF stays active longer. The window for clot formation stays open wider. It's a compounding problem, not a single factor. I had a 67-year-old patient, type AB, blood pressure well controlled, non-smoker, regular walker, who came in with an ischemic stroke affecting the left hemisphere. No atrial fibrillation, no obvious embolic source. The clot didn't form because of a dramatic trigger. It formed because of a clotting system that had been running in overdrive for years, in a vessel that could no longer absorb it. That is the mechanism, and understanding it is exactly what makes the next part possible. Here's where I want to be direct with you, because this is the part that actually matters for what you do next. You cannot change your blood type. That conversation is closed. The ABO gene you were born with is the ABO gene you will die with, and no supplement, no diet, no procedure changes that. What you can change, meaningfully, measurably, is the environment your blood operates in. And for non-O types over 60, that distinction is not a consolation prize. It's a genuine clinical opportunity. VWF is not a fixed number. It responds to what you do with your body. The same endothelial cells that release excess VWF when they're stressed and inflamed release less of it when they're functioning well. That means the behaviors that protect your vascular lining directly affect how much VWF is circulating in your bloodstream on any given day. Even a 10 to 20% reduction in VWF activity translates to real, meaningful cardiovascular protection. Fewer platelets recruited unnecessarily. Fewer clots forming in vessels that can't afford them. One of these interventions surprised me when I first looked at the data. Not because it's exotic, but because it's something most people already do, just not in a way that protects them. I'll get to that one specifically. Start with aerobic exercise, because the evidence here is the most consistent. Meta-analyses on moderate aerobic activity, walking, cycling, swimming, anything that gets your heart rate up for sustained periods, show VWF reductions of 10 to 25% over 3 to 6 months in older adults who commit to roughly 150 minutes per week. The mechanism is direct. Sustained movement increases shear stress on your vessel walls, which stimulates the endothelium to produce nitric oxide. And nitric oxide is one of the most powerful vascular protectors your body makes. It relaxes blood vessels, reduces inflammation in the vessel lining, and signals endothelial cells to hold back on VWF release. 30 minutes of brisk walking 5 days a week is not a lifestyle suggestion. For a non-O-type over 60, it is an active intervention against a biological tendency. Diet follows a similar logic, but with a more specific target. A crossover trial in diabetic patients, a group with consistently elevated VWF, found that shifting to a high MUFA diet reduced VWF by 12.5% in just 3 weeks. MUFA stands for monounsaturated fatty acids, and the practical translation is olive oil, avocados, and nuts as your primary fat sources, replacing refined carbohydrates and saturated fats rather than just adding to them. The mechanism is reduced endothelial inflammation. When you lower the chronic irritation in your vessel walls, you lower the stimulus that triggers VWF release. 3 weeks is a short enough timeline that this isn't theoretical. You can test it in your own next blood panel. If you smoke, stopping is the single highest leverage action you can take for your VWF levels specifically, not just for cardiovascular health generally. Smoking directly injures endothelial cells, the same cells responsible for releasing VWF, and that injury is cumulative. Observational data shows VWF dropping 10 to 20% within 12 months of quitting. The damage from smoking isn't just lung damage. It's vascular lining damage that actively drives the clotting protein elevation you're trying to reduce. Weight carries a similar direct relationship. Adipose tissue, body fat, particularly around the abdomen, drives chronic low-grade inflammation throughout the body, and that inflammation chronically stimulates VWF production. A 5 to 10% reduction in body weight in obese older adults correlates with roughly 15% lower VWF levels in longitudinal studies. You don't need dramatic weight loss. Meaningful weight loss is enough. One factor that almost never gets mentioned in this context is hydration. After 60, thirst sensation becomes blunted. Your body's signal that it needs water becomes less reliable, and many older adults are in a state of chronic mild dehydration without ever feeling particularly thirsty. Dehydration thickens blood, slows flow velocity, and raises viscosity, all of which raise clotting risk independent of VWF levels. 8 glasses of water a day isn't optional at this stage. It's part of the protection plan. And it's the intervention I was referring to earlier. Not because drinking water is a surprising idea, but because most people over 60 are chronically underhydrated without knowing it. And that alone is quietly working against everything else on this list. These are the foundations. But there's a second layer of protection most people, and honestly, many doctors, never get to. And it starts with a conversation that probably hasn't happened at your last few cardiology appointments. Here's something I want you to understand about how standard cardiovascular care works, because it explains a gap that affects millions of older adults with non-O blood types. When your doctor orders a cardiovascular panel, they're looking at cholesterol fractions, triglycerides, blood glucose, maybe a C-reactive protein if they're being thorough. That panel is designed to catch the most common risk factors across the broadest population. It was never designed to capture blood type-specific clotting risk. So VWF antigen levels and factor VIII activity, the two numbers most directly tied to the mechanism we've been discussing, are not on it. They're specialty hemostatic tests, the kind that typically get ordered when a hematologist is already investigating a bleeding disorder. For thrombotic risk assessment in older adults, they're almost never requested. That means most type A, B, and AB patients over 60 have never seen those numbers. They don't know if their clotting activity is running high or higher. They're managing a real biological risk factor they've never actually measured. You can fix that with one conversation. If you have a non-O blood type and you're over 60, particularly if you also have hypertension, a family history of stroke, diabetes, or atrial fibrillation, ask your doctor to add VWF antigen and factor VIII activity to your next blood panel. You can say it simply. I have blood type A, or B, or AB, and I'd like my clotting factor levels checked as part of my cardiovascular risk assessment. That framing puts it in the right context so the request doesn't get waved off. If those numbers come back elevated, that's not a reason to panic. It's a data point that tells you the lifestyle changes we covered, the exercise, the diet, the weight management, need to be treated as non-negotiable, not optional. It also opens a real conversation about whether your current medications are actually calibrated for your clotting profile. For anyone dealing with atrial fibrillation specifically, the picture becomes more urgent. AB blood type in AF patients showed a hazard ratio of 2.01 for major adverse cardiovascular events in real-world data, and that figure held up independent of anticoagulation duration and CHAD-2DS2 VASC score, which is the standard clinical tool doctors use to assess stroke risk in AF. What that means practically is that the standard risk calculation may be underestimating your actual risk if you have AB blood type. Your cardiologist needs to know both facts simultaneously, not just one. There's one more marker worth asking about. D-dimer is a byproduct of clot breakdown. When your body forms and dissolves small clots, D-dimer rises. In older adults, a chronically elevated D-dimer isn't always caused by an acute event. It can reflect ongoing low-level clotting activity that your body is quietly managing, a pattern that sometimes precedes a larger event by months. It's an inexpensive test, it's widely available, and in combination with VWF antigen, it gives you a clearer picture of what your blood is doing between appointments. Getting these numbers doesn't require a specialist referral in most cases. It requires knowing what to ask for. And now you do. Once you have those lab numbers, the medication conversation becomes more specific. And there are a few things worth knowing before that appointment happens. Blood thinners, the kind cardiologists prescribe for clot prevention, are dosed based on average clotting physiology. But recent trial data found that type A patients on these medications needed 10 to 20% higher doses to get the same level of protection as type O patients. The standard dose may simply not be enough. If you're already on a blood thinner, it's worth asking your prescribing physician whether your blood type was factored into the dosing conversation. In most cases, it wasn't. Aspirin occupies a more nuanced position. Current guidelines don't recommend low-dose aspirin as a blanket preventive measure for older adults, and that hasn't changed. But for non-O types over 60 who already carry 2 or more conventional cardiovascular risk factors, blood type adds meaningful weight to the individual risk-benefit calculation. It's not a decision to make based on a video. It's a decision to bring to your cardiologist with your VWF number in hand and your blood type on record. Statins are worth discussing separately because most people think of them purely as cholesterol drugs. They're not. Statins reduce endothelial inflammation, and as you now understand, Inflamed endothelium is the trigger point for excess VWF release. For non-O types with elevated LDL, and type A specifically does associate with higher LDL cholesterol through a separate genetic pathway, statins are working on two problems at once. Cholesterol management is the reason most doctors prescribe them. Vascular lining protection is a second benefit that directly addresses the mechanism we've been discussing. There's one medication worth flagging for the opposite reason. It's occasionally prescribed for mild bleeding issues in older adults, and it works by triggering the release of stored VWF into the bloodstream, which is exactly what you want when VWF is too low. In non-O types, it pushes an already elevated level even higher. If you or someone you care for is ever prescribed it, your doctor needs to know your blood type before that prescription is written. Now pull all of this together because the plan isn't complicated. It just requires deliberate action. Know your blood type. Get your VWF antigen and factor VIII activity tested. Commit to 150 minutes of moderate aerobic exercise each week. Shift toward olive oil, avocados, and nuts as your primary fat sources. Stay properly hydrated, and if you carry excess weight, even modest reduction moves the numbers. Keep blood pressure below 130/80 and have an explicit conversation with your cardiologist about whether your current regimen accounts for where your blood type sits on the clotting spectrum. What we covered today is the internal picture, the biochemistry running in your blood that most standard panels never catch. Know your blood type, get those clotting factor levels checked, and bring what you've learned into your next cardiology appointment. That conversation alone could change what gets measured, what gets treated, and what gets caught before it becomes a crisis. But there's a second layer of stroke risk after 60 that no blood test will show you. It shows up in something most people dismiss entirely, something as ordinary as the way you walk. The same arterial damage that drives clotting risk also affects how your body moves, and cardiologists are now using it as a measurable early warning sign. Most people over 60 already have it. Almost none of them know to look for it. That's the next video. It's on your screen right now.